mic's on mute, isn't it? How do you know that? Is there a, just to make sure?
All right, I think it's time to start. Good morning and welcome to Medicine Grand Rounds. Dr. Roman is out of town. He asked me to be the master of ceremonies. So as you know, he always gives you some historical anecdotes, and Jason and I looked very hard for the source of this information. We couldn't find it. So that's one of the great mysteries of the universe. Where does Dr. Roman get all these dates, what happened 100 years ago or 50 years ago and so on? So sorry, I cannot give you those anecdotes. And I don't know what happened 100 years ago today, but I know what will happen today, which is we have Dr. Stephen McClave giving us grand rounds on nutrition therapy. And I know Dr. Kruger will introduce him, but I just want to say one thing about Steve is that he's a great skier. And he and I enjoy Paioli Peaks and Perfect North also, right? Perfect, both places. So we talk a lot about skiing. But anyway, and without further ado, I'd like to invite Dr. Kruger to introduce Dr. McClave.
Thank you. You all know Dr. McClave is originally from Columbus, Ohio, and attended Ohio State University. His father was a pediatrician on faculty at Ohio State. He received he went to do residency at MUSC in Charleston, South Carolina, and then trained for gastroenterology at University of South Florida. Louisville's been lucky to have him his entire career. He's a tenured professor with over 200 publications, and it's very fitting that he's talking about nutrition today. I don't know if you residents are aware how lucky you are and students that might be here. 2/3 of medical schools do not have any formal nutrition on their curriculum in medical school. Only 1/3 do, and with very little support. And Steve does the bulk of the teaching, and all of the dietitians in the hospital every week sit down and meet with him and discuss literally every patient's nutrition needs. So we really owe a big thanks to him to begin with for educating and being one of the only faculty that really commits a lot of time educating in nutrition. So as we enjoy eating our bagels, we'll get to hear about nutrition in the ICU. Thanks, Steve.
Thanks.
Good morning. It is absolute crazy times in clinical nutrition right now because of a movement that's taken place that suggests that maybe we should be backing off and feeding less in the hospitalized patient, particularly in the ICU. Some people have taken that a step further and said, we should do no forced mandatory feeding in the first week of hospitalization. And the implication from this movement is that, we probably paid too much attention to nutrition. It's not that important. And man, it's lower on our list of priorities. This morning, I'd love to say I'm going to set the record straight, but I can't because this is an evolving field. But what I want to do is arm you with the information, because we're going to see more of these studies come forward emphasizing that we should feed less. And you need to have the information and understand who we need to push and provide as close to goal as possible, and who it might be okay to back off and feed less. Trophic feeding, that concept has been around my entire career, since the late 70s and early 80s. And it's defined by 10 to 20 cc's per hour. Now, to put that in perspective, that's right at a tablespoon an hour of formula in somebody who's critically ill in the ICU. So there are two messages that I want to get across as I go through this information, and keep this in your back of his mind as we go through these trials. Number one, that the true benefit of nutritional therapy is related to early tube feeding, enteral nutrition. We do not know what the role is of TPN in the hospitalized patient, and it doesn't look like there's a benefit outside the setting of intestinal failure or short bowel. So anybody that lumps them together and says that all nutrition is bad, the red flags go up and say, hold it, pal, we got a problem. The second point is that whether or not we need to aggressively feed somebody and push toward goal is determined by their nutritional risk. And nutritional risk is dependent on two things: nutritional status and disease severity. And if they're at high risk, you got to be pushing and getting as close to goal as possible. If they're mild to moderate risk, it may be okay to back off and feed less, and in some cases, not feed at all for that first week. 4 years ago, we published these guidelines jointly in JPEN and Critical Care Medicine, and this was the guidelines for providing nutritional therapy in the adult hospitalized critically ill patient. And there are lots of guidelines out there, but we were really proud of these for a couple of reasons. It took us 5 years to develop, and absolutely every line was transparent. You could tell exactly what studies we got this recommendation from and why we made the recommendation. But the part that we were proud of was very clinical. And we wanted people at the bedside to have guidance into as many of the aspects of feeding as possible. In the 4 years since it was published, it's been challenged like crazy, and it's held up really well. We're now in the process of revising them. And the message throughout these guidelines was the importance of early and aggressive enteral feeding, that you need to start early and get close to goal as possible as soon as you can in order to change and improve outcome. Now, the bombshell that shook this concept came in February, and this was the Surviving Sepsis Campaign. This was the third round of their recommendations, but the first time that they decided to put in nutritional recommendations. And when the nutrition community saw them, we went, oh man, we're in trouble. If you read through these, some of them I actually agree with. The first one, start oral diet or enteral nutrition within 48 hours of the diagnosis of sepsis. I would agree with that. Most of us would agree with that. That one's fine. But then the first of three bombshells was here. Avoid mandatory full feeds, whatever that means, and give 500 calories a day for the first week. Number two, use IV dextrose with your tube feeding. That's goofy. And we come back to that in a second. I would be embarrassed to have that in my guidelines. But here's the big part. No TPN, and whatever you do, don't add supplemental TPN to your tube feeding in that first week. And then the last landmine, whatever you do, don't use immunonutrition. Now, surprisingly, I would agree with all of this except for this one. You wouldn't back off on every patient and provide 500 calories a day. There's a whole group of patients that would need more, and that's probably the one I have the most trouble with. But this really shook the landscape and changed our thinking. Now, as I go through these studies, it's important to remember that perspectives can vary. You can present a study and you think that your perspective and your interpretation is as straightforward as possible, and then some fool will come up to the podium and have the exact opposite reaction. You think, how is that possible? I mean, we could be talking about something as simple as like Mount Rushmore, and you'd think that our American perspective is the only one that's possible. But think how the Canadians see this topic. So as I go through this, what I think the important thing is to get the facts on the table and then argue about your perspective of the facts, because as you know, your perspective is always the right one. It's easy to argue. Now, the reason I make this point is the perspective of this Surviving Sepsis Campaign was that they only count on big randomized trials. And if you think about them, a lot of times they're looking at cardiology studies where they have 10,000, 30,000 patients. They don't like our observational studies in nutrition. They can't stand our small RCTs, and they go nuts because they think we rely too heavily on meta-analysis. They say, we don't want to hear that stuff. We want to focus on the big boys. And if that's your prism, your perspective, that you're looking at the information, then the only two studies that are going to tell you how much to feed in the ICU to this Surviving Sepsis Campaign committee would be the ARDSNet trophic feed study and the CSAR EPANIC study from Europe on supplemental TPN. So we're going to look at these two studies closely to try and figure out how the Surviving Sepsis Campaign came to their recommendations. Ruth Vandenberg is an absolute amazing investigator. She was the one that did the tight glucose control, and it was described as a tipping point. We've all altered the way we manage glucose because of her. Well, then she took on supplemental TPN. This is the EPANIC study, and it was designed in ICU patients who were on tube feeding, and then they were randomized to either get supplemental TPN on day 3 if the tube feeding wasn't getting the job done, or day 8. And in the methodology, she actually set up a dogfight because she said this reflects the European ESPEN guidelines, and this late TPN group reflects the American ASPEN guidelines. So from the get-go, it was a dogfight. We all kind of waited to see which way the axe would fall. When the results came out, we felt good. We felt lucky because it looked like our recommendations did better. The group that got early TPN, every endpoint they followed was worse. From length of stay to infection to the likelihood of being discharged alive to healthcare costs were all worse if they got TPN on day 3. Now, right off the bat, this is the largest study in the history of clinical nutrition, a randomized trial, 4,600 patients. And this has been scrutinized by more people than you could ever imagine. Immediately, everybody said, we can't stand the tight glucose control. Vandenberg's the only one that does this. Everybody else does moderate glucose control. But the two big arguments that really caught in everyone's craw was down here. First, that she gave a big IV glucose load to that early TPN group. On day 2, she gave 400 calories of carbohydrate IV. Next day, day 3, she gave 800 calories of glucose, and then she started the TPN. And everybody said, nobody does that, and you're poisoning them with all this glucose. No wonder they did worse. The second criticism was that the patients weren't that sick. 60% were elective cardiovascular surgery patients that got an operation and went to the ICU. And the Europeans said, these patients weren't that sick. They wouldn't even get TPN at our institution. So we don't even want to listen to this study. Well, 11 months later, now December of 2012, she came back with a post hoc analysis. Now, this already gravels me and irritates me a little bit because she's bad-mouthing us for looking at small RCTs. Statisticians don't like post hoc analysis. That's kind of a dirty pool. But she came back, and the first thing she did was address this impact of disease severity. And it was important to me because I was nervous about giving TPN, and I didn't want to just throw this study out completely. And what she showed here was that this is a forest plot with increasing range of Apache scores. So 10 to 15, 20 to 25, 25 to 35, and then over 35. And the point is, the sicker you get, and you got early TPN, the less likely you were to be discharged alive. The sicker you got, and you got early TPN, the more likely you were going to get infection. And the only group that didn't was this very high Apache group. They may have been pre-terminal. So the point was, the sicker you are in the ICU, if you get early TPN, you do worse, not better. And then she looked at the defense of the IV glucose, and here her tone changed a little bit because everybody's bad-mouthing her for giving IV dextrose. This is a forest plot turned on its side, looking at whether or not you're discharged alive. In the yellow is the glucose. So she said, and the glucose here is flat. From day 2, day 3, day 5 to day 7, it's flat. It didn't matter whether you got glucose on day 1 or day 7 or in between. The glucose didn't affect whether you were discharged alive. It was the green, the protein. If you got extra protein on day 3, you were less likely to be discharged alive than if you got it later. And so she was starting to say it's the nutritional therapy, not the IV glucose, that's causing trouble. And then she provided these boxes. And here we have, down here at the bottom, we have from 0 to 100% of goal feeding. And this is likelihood of being discharged alive on day 3, day 5, and day 7. And she says, look at this. The more nutritional therapy you get on day 3 and day 5, the less likely you are to be discharged alive. That means we should avoid forced mandatory feeding. By day 7, it's no longer significant. And she found a mechanism of convenience, autophagy, to explain this. And autophagy, I'm just struggling to understand now, and it's very complex. It's been around since the 1970s. This is not a new concept. But she says that this forced mandatory feeding is causing worse outcome because it suppresses autophagy. Now, autophagy is a mechanism by which the cell hangs in there and stays alive as oxidative stress is building. And what happens in increasing oxidative stress is the endoplasmic reticulum starts screwing up protein folding. You know, proteins have to be made and then folded to become active and functional and become structural. If that gets misfolded, they don't work. And as the cell gets more and more screwed up because of oxidative stress and that process builds up, the more misfolded proteins, it begins to act like endotoxin and can interfere with insulin receptors, causing insulin resistance, and can eventually lead to apoptosis and necrosis. So you want autophagy to maintain the structure of the cell, otherwise you break it down and break down lean body mass. So she says we have to not feed so that we don't suppress autophagy. Now, right off the bat, there's so many problems with this. For example, I thought we were feeding to maintain lean body mass, and now she's saying we got to stop feeding so that autophagy can maintain lean body mass. That doesn't make any sense to me. Then the next thing she says, she's not aware of the fact that the glutamine in the feeding we provide, glutamine stimulates autophagy. So there's lots of problems with this argument. So how would we interpret it, this large trial at this point? Well, the Americans would say, based on this EPANIC study and the reanalysis, that enteral and parenteral calories are not the same thing. They have a different risk-benefit ratio. The benefit is from enteral tube feeding, and this is a liability. It may be the early TPN that's bad. Surprisingly, Canadians and Europeans did not want to talk about it. And literally, I'd be at a meeting, I'd say, what about the EPANIC study? And they'd go, they'd put their fingers in their ears and didn't want to talk about it. And then here's Vandenberg out on the far edge of this envelope saying, look, all nutritional therapy is bad, no forced mandatory feeding. Well, let's come back to this reanalysis because I think she's interpreting the data incorrectly. This is the figure from her original study. The blue is the early TPN group, orange is the late TPN group. On this side is what they got by tube feeding. And you can see that every day of the study, they got the same amount of tube feeding, both groups. So any difference in outcome can't be related to the tube feeding. On this side is what they got by parenteral TPN. So these blue bars here is that early group getting the early TPN. Guess what this is right down here? That's the dextrose, 5% dextrose in their IVs. That's where the surviving sepsis got that goofy recommendation. Well, just add your dextrose to the tube feeding, as if that's a valuable meal in itself. I have problems with that. This was a point to drive home about the liability of TPN. There were 500 patients in this study where the bowel was in discontinuity and couldn't get any tube feeding. If they got TPN on day 3, their outcome was worse than if they got it on day 8. Infection was higher, their chance of being discharged alive was worse. So this said TPN is a liability, even when you can't feed anything through the gut. And then this is also provided in the analysis. But look at this. We now have taken the 3 boxes I showed you before, but now we're showing them this is the early TPN group, and we're talking about the first week when they got the TPN. This is the late TPN group. So nobody down here has gotten any TPN at this point. The effects that she was describing in those first 3 boxes is accounted for by the early TPN group. If you look down here in the group that's only getting tube feed, none of these points are significant except for this one right here. This is from 0 to 100% of cold feedings on day 3, 5, and 7. None of these are different except this point right here. And you can't read this, but there are only 2 patients that formed that line out of 4,600. So this adverse effect that she's talking about is related to the early receipt of TPN, not the early receipt of tube feeding. And yet she has lumped them together into forced mandatory feeding. That's why red flags got to go up when somebody starts doing that. Now, I told you that the Canadians and the Europeans didn't want to talk about the EPANIC study. So they jumped to this study to continue to defend the use of TPN. And this was a trial from Switzerland in which all patients were started on tube feeding, and on day 3, if you were below 60% of goal calories, you were randomized to have TPN added to the tube feeding or keep slopping along with the tube feeding you were already on. At the point at which they presented an abstract at the international meetings, they had 275 patients in the study. And look at this. It looked like adding the supplemental TPN to the tube feeding reduced new infection, shortened duration of mechanical ventilation by 3.5 days, and got you out of the hospital almost 3 days sooner. Now watch this. This is at 275 patients. They finished the study 25 patients later at 300 patients, and guess what happened? 2 of the endpoints fell out and were no longer significant. Now the only difference was nosocomial infection. But this is goofy. It was difference in infections after day 9. That's the point at which the difference in infections separated. And the important infections, central line infection, pneumonia, abdominal abscess, no difference between groups in those important infections. The difference in infections was the other infections, and this is a direct quote. The nose, skin, ear infections, the deadly ones that scare all of us, that was the different. That was the different one. And so they said, okay, well, shoot, that didn't help our thinking. Let's jump to this one. And I love this. This is Gordon Doig. This guy is the oddest guy I've ever met. He's a veterinarian who has gone back and gotten a PhD in epidemiology and is now telling us what to do with critical care patients. And I guess that's no different from a gastroenterologist telling you what to do in critical care patients. But this study was a large prospective randomized trial. And to get in the study, if the attending thought you might have trouble with tube feeding in the next 3 days, then you were entered in the study and randomized either TPN or do nothing. They followed every parameter known to man, including quality of life, in addition to infection, organ failure, duration of renal therapy, duration of mechanical ventilation. At the end of this huge study, the only difference was the duration of mechanical ventilation was 1 day shorter in the group that got TPN. Everything else was no difference. When he presented this at the national meeting, I happened to be the moderator of the symposium, and he's acting, he wasn't published yet, and this was a big secret, and he was going to let us in on just 1,000 of his closest friends. He was going to give us the details of this, but he couldn't give us all the details. And I was very proud that I got off the podium without saying, Gordon, why don't I even want to hear the rest of this study? This is a negative study. I wanted to scream that from the podium. So now, how have we revised our interpretation at the basis of the reanalysis and these 2 additional TPN studies? Well, now the Canadians have come over to our thinking, and most of the European leaders, who are now saying that, yeah, we do agree that enteral and parenteral are not the same thing, different risk-benefit ratio. Based on those latter 2 studies, the Swiss study and the Doig study, TPN can be done safely, but the benefit is just not clear. Outside of intestinal failure, it's just not clear that it's helping anybody in the hospital, and you need to use on a case-by-case basis. Gordon and some of the holdouts, some of the hardliners in Europe are still saying if you do TPN properly, it can benefit the patient, use readily if you don't make it on tube feeding. And then you got Vandenberg still out here unshaken saying don't give any nutritional therapy for the first week. And the second study that supported what the Surviving Sepsis Campaign was doing was the trophic feed study. And this study shook me more than any other study in this bunch. And that's because it was so well done. It was done out of Vanderbilt. Todd Rice is a young investigator there, great guy, good friend. He promised to call me the minute the results were in. He called me, and it was a long day at the McClave house because this really shook me. But these were patients with ARDS randomized on admission to either trophic feeds, which was 20 feeds an hour for 6 days, then advanced to full, versus full feeds. At the end of the study, that 20 cc's per hour really ended up being 25% of goal calories, and the group that was supposed to get full feeds got about 80% of goal calories. And then when you looked at the endpoints, you probably have all heard this story. It was absolutely equal between the 2 groups. And then we said, every parameter they could think of, no difference between the 2 groups. And then we said, well, look, 6 days of this trophic feeding, I'll bet they had trouble 6 months later when they were trying to get out of the nursing home and go back home. They followed them for a year. No difference between the 2 groups. In this group of patients, trophic feeds were just as good as full feeds. Now, how is that possible? Well, when you look at the details, there are some things that explained it. First of all, the patients weren't that sick. They were middle-aged, 52. They had a healthy, maybe over-healthy BMI, average 30, and they had a short stay in the ICU. They screened 8,000 patients to end up with the 8,000 that were in the study. And the 7,000 exclusions were anybody that was sick. If you had liver disease or lung disease, if you had a low BMI, the malnourished ones, you couldn't get in the study, you were out. If you had severe shock, if you were severely ill, you didn't make it in the study. It may be that 25% goal calories is enough to get the job done, at least in this group of patients. And we have another study that as long as you got about 25% of goal calories, you remain free of bloodstream infections. So maybe that's enough. Another aspect is that maybe dose isn't the biggest issue. Maybe it's the early initiation. Todd became a very good nutritionist through the course of this trial. And patients were started within 6 hours of randomization on their tube feeds. And the nurses forgot about the trophic feeds and would leave it on when they did bed baths or send them for an x-ray or something. And maybe it's the minimizing interruptions that's more important than the dose. One important thing was there was a 1.5 liter difference in fluid provided to the trophic feed group. And the Arsenet people are famous for their moderate fluid resuscitation principle. And, fluid in the lungs is horrible in somebody on mechanical ventilation. So that may have been a factor that made them perform just as well as the full feeds group. And then one other point was their BMI. This is a graph from a Kathy Alberta, Darren Highland study that looked at different ranges of BMI and said if you go from 500 calories to 1,500 calories, does your mortality go up or go down? Well, this line here is the BMI below 20. If you're a little stick and you're critically ill and you get 1,000 more calories, that's easy to understand how their mortality would go down. The surprise was the patients with a BMI over 35 and above 40. If they went from 500 calories to 1,500 calories, their mortality also went down. Now that's maybe because 500 calories is a drop in the bucket and you're just starting to get into the range when you get to 1,500. I don't know. But the important point was in the middle was the group with a BMI of 25 to 30 and 30 to 35. And that group, it didn't matter how much calories you got, you didn't change outcome. This happens to be a group of patients where nutritional therapy, we may need to do it, but it's less likely that the nutritional therapy is going to change outcome. The key issue here is, are these findings unique to this population? Would we use the same strategy in somebody with severe pancreatitis? I don't think so. I think that's dangerous thinking. If 20 cc's, 1 tablespoon an hour, it does the job, maybe doing nothing is just as good. No, this does not okay you to just not feed at all. Nothing says that. And as trophic feeds better, it's not better, it's the same. And be careful, if you order a tablespoon an hour, in our hospital, we've done studies, you'll get half of that tablespoon. You'll get a teaspoon and a half. Now, how does this trophic feed match with everything else we know about clinical nutrition? There are 5 bodies of literature that suggest that feeding less is not the right idea, that feeding more is the right idea. And let me just quickly go through these 5 bodies of literature. The first is early versus delayed tube feeding, with the average cutoff being 36 hours. And we have 18 randomized trials, 3 or 4 meta-analyses that show that if you get feed started within the first 36 hours compared to feed started after that, you're going to have a reduction in infection by half, hospital length of stay reduced by 2 days, and there is a mortality benefit with these early feeds. And this is a polymeric meta-analysis here that is looking at several different groups: abdominal surgery, trauma, burns, head injury. It doesn't matter. If you're critically ill, starting early is better. Second body of information, body of studies is enteral feeding versus do nothing. In the literature, that's called standard therapy. Here we have 16 randomized trials in surgery and surgery critical care, 2 in a severe pancreatitis being operated on for complications. The design is the same. They're on the table in the OR, and they open an envelope, and they either get aggressive use of the oral route the next day or tube feeding versus do nothing standard therapy. And in 2 meta-analysis by Lewis, infections were reduced by 28%, hospital length of stay by 1 full day, and there was a mortality benefit, absolute reduction from 7% down to 2% if you fed the day after this big operation. And in the pancreatitis study, the absolute reduction in mortality was 25 down to 6%, and it just missed significance. The third body of literature is the caloric deficit concept. This is the idea that every day you're expending calories. I would expend about 2,000 calories a day if I were in the ICU and critically ill. When they first started 30 years ago, they were focusing on a 10,000 calorie deficit. It would take me 5 days to get there if nobody was feeding me. But the Europeans have shown that as little as 4,000 calorie deficit, for me that would be 2 days. If it took you to the third day to get your tube in me, I would be behind the 8 ball by 4,000 calories, and all these outcomes would be worse. Now, this is the weakest of the 5 bodies because the sicker you are, the harder it is to get the calories in. But that's supplemented or supplanted by the fourth body of literature that looks at the impact of a nurse-driven protocol. And every time you have a protocol where it says, put the tube in, go by this rate, fixes the right number for residual volumes, invariably patients get more tube feeding that first week. And what happens when you stand back and look at the overall effect, 4 randomized trials, 3 before and after implementation of protocol, outcome gets better. Length of stay, complication, infection, and 2 of these, mortality gets better. And then the fourth or fifth body of literature is all the mechanistic data that we've accumulated in 3 decades of research. Now remember, it's all of this, like maintaining gut integrity, affecting both the innate and acquired immune responses and down-regulating inflammation in the SIRS response, shutting down this axis of inflammation where the gut sends cytokines directly to the lung, maintaining the role of commensal organisms. I mean, it goes on and on and on, all the mechanisms that reduce inflammation and make them recover quickly from their SIRS response. It's these mechanisms versus Vandenberg's autophagy, which I think she's kind of got screwed up anyway. So at this point, how would you look at the trophic feed study that Todd Rice did? Most of us would have this perspective that brief trophic feeding is okay in this patient population that is at moderate risk. Unfortunately, this is what's happening. That, boy, if that worked for them, the Surviving Sepsis Campaign Committee writes the rules in the ICU anyway. They're law. Now everybody's saying that trophic feeding is the best for all ICU patients, and that's a problem. Quick comment on immunonutrition because they trashed that. And this was another big adjustment for me. I loved immunonutrition. And immunonutrition is the idea that we're already getting a benefit from our tube feeding, and now we're going to add extra agents like arginine and fish oil and glutamine to get an even bigger bang for our buck. Well, it's been a horrible year for immunonutrition. 2 big negative studies with fish oil, 4 big studies negative for glutamine showing absolutely no benefit. We come back to the Surviving Sepsis Campaign Committee with their focus, their goggles of don't give me the small stuff, let's talk about the big boys. Then they're going to focus on the other half of the ARDSNet study, the Omega trial that looked at bolus fish oil, and they're going to focus on another study that was published just this year, the Canadian Redox trial. The ARDSNet study was a 2x2 design. We already talked about the trophic versus full feeds. The other half of it was this fish oil supplement versus placebo. And halfway through the study, when they did the interim analysis, look at this. The mortality rate was higher in the group that got the fish oil supplement. And so they stopped it, and they said, this is futile. This group is doing so good. This is the lowest mortality of any control group in the history of the ARDSNet research group. They've been doing studies for 20 years. This is the lowest mortality. So they said, it's futile. These guys are doing so good, this fish oil could be magic, and it would never catch up. So they stopped the study. But guys like this guy in the Thoracic Surgery News that year said, you know, it looks like the fish oil is killing people. And I would attribute this to the fact that it was bolus feeding. You give, if you really want to change out the phospholipids in the membrane, the fish oil needs to be given continuously. But interesting, Todd Rice says, you know, I don't think we should just dismiss this as futile because this was such a good group. He says every year the mortality in the control group gets lower because we're getting better at what we do. And he goes, if this is worse, you know, maybe the fish oil was doing something bad. And we know, and there's a dictum in nutritional therapy, when you're given lipids by vein, you go low and slow. Because if you give it too fast, you clog RE cells and you screw up macrophages. So this might be real. We don't know. But it clearly was a negative study. And then this study was a huge downer. This was a study where patients were randomized either antioxidants, yes or no, or glutamine, yes or no. And the glutamine was given parenterally and by tube feeding. At the end of the study, The group that did the best was the placebo that got neither. And fortunately, there was no difference, significant difference in the antioxidants, yes or no, but there was a significant difference between the glutamine. In fact, the glutamine, the odds ratio, if you got glutamine, you had a 20%, almost a 30% increase in dying from the glutamine. And Darren, I was on the phone call when he went over the results, and he was just absolutely distraught and thought he was killing people with the glutamine. A lot of statisticians would say that an odds ratio below 2, you're not sure if it's cause and effect or noise or confounding variables. We don't know, but clearly no benefit. So where do we stand with immunonutrition in the critically ill patient, hospitalized patient? Well, guess what? We just don't have an effect. These are 2 forest plots from critically ill ICU patients and major elective surgery. And this is the group, Darren Hyland's group, that tracks these things. This is looking at infection. In the surgical patient undergoing a major elective operation, there's a very uniform effect in which an arginine fish oil formula would reduce infection. But look at the medical ICU patients. It's flat as a fiddle, no effect. And if you look at ICU length of stay, mortality, absolutely no effect. There's no benefit in the critically ill patient in the ICU, medical ICU, from immunonutrition. So the surviving sepsis group was right on this one. So where do we stand on immunonutrition? In elective major operation, we would use an arginine fish oil formula because it reduces infection and hospital length of stay. In critical care, we can no longer recommend it. In ALI, ARDS, we would still recommend it because we still have randomized trials that suggest that organ failure, ICU length of stay, and mortality is reduced. And the only problem is one of negative controls. The control group got Pulmicare, which has a lot of immunosuppressive fat, and they think that it was a negative control. But the bigger reason is the credibility of one of the investigators. This guy's from Brazil. Nobody at Brazil lets him present at the Brazilian meetings because they think he makes up his data. We tried to get him to present the patients. He wouldn't present the patients. He wouldn't give us the data. He says, I can't because of IRB issues. He can't because we don't think they existed. He trolls the ER looking for septic patients. If you have a high white count, you're septic, you come up to the ICU, he starts doing studies on you. So a lot of people, this isn't catching traction, but it's the data would support it, but nobody believes it. So I want to finish with these couple concepts. So who does benefit from nutritional therapy? Who needs a lot of nutritional therapy? Well, that depends on how you define malnutrition and nutritional risk. There was an international committee recently put together by ESPN and ASPEN to redefine malnutrition. Because you know what? We don't know what malnutrition is. And this committee worked for months, and this is what they came up with. Starvation-related, chronic disease-related, acute disease-related malnutrition. That doesn't help me at all. All they did was introduce the concept that inflammation is a factor in this concept, whatever malnutrition is. The Europeans, I think, got it right. When they stopped using the term malnutrition and said, let's talk about nutritional risk, because we can define that. And nutritional risk is defined by 2 things, poor nutritional status and disease severity. And let me show you what I mean. This is the NRS 2002. It's not great, but it's a great concept. And that is that nutritional risk is determined by impaired nutritional status and disease severity. So here you have 1, 2, or 3 points, and it's based on weight loss within 3 months, 5% weight loss within 2 months, or 1 month. If your BMI is between 18 and 20, or if it's below 18, or if your intake is below 25% or 50%, you get increasing points. And then over here, you look at disease severity, either based on the disease itself, like diabetes or cancer or COPD, you get 1 point, or a major operation or pneumonia, you get 2 points, or head injury or ICU with a high enough Apache score, you get 3 points. And then you add them all up and add a point if they're over 70. If they have 3 points, you should consider supplemental nutritional therapy. But if they have 5 points or more, they're at high risk. Now, how does this play out? Here's a prospective study in surgery patients getting nutritional therapy before a big operation. Out of 1,000 patients, 10% or 120 had this high score, identifying them at high risk. And then they looked at whether they got sufficient nutritional therapy or insufficient. Sufficient was not a lot. It was 10 calories per kilogram per day. which is about half of what the goal was. But they said as long as they get that much in that week before surgery for 7 days, we'll call that sufficient. At the end of the study then, out of these 120 patients, and these guys were sick. These were surgery patients that got pneumonia, abdominal infection, and had anastomotic leaks. If they got sufficient nutrition before the operation versus insufficient, look what happened to overall complications. Cut in half, infection, cut in half from 30 down to 16%. If their scores were low, it didn't matter if they got a lot of nutrition or a little bit, their outcome was the same. So if your nutritional risk is high, you need to get the nutritional therapy into them to change outcome. The second scoring system is the Nutrix score. Same thing as the NRS 2002. It looks at disease severity by Apache score, SOFA score, which measures organ failure, number of comorbidities. Their marker of malnutrition is the time from hospital admission to your ICU admission. The longer you sit out on the floor and then go to the ICU, the more malnourished you are, and they have references to support that. And you simply add up the points. The higher the points, the higher the risk. And look at this. If you're low risk, if your score is 0 to 5, down here is feeding from 0% to full 100% full feeds. No difference. This line is not significant. This is mortality. But if your score is high and you're high risk, the more nutrition you get, there's a statistically significant reduction in mortality. So it drives home this point that you need to evaluate nutritional risk, and if they're at high risk, you don't play around. You make sure and give them adequate nutritional therapy and get as close to goals as possible. And how high do you need to get? You need to get over 80% to achieve this outcome effect. That means you have to have strategies in place. And here at University Hospital, this is one thing we're pretty darn good at. Volume-based feeding, where we say you got to get this volume in every day. And if they go down and screw around in the CT scan, come back up, the nurse can increase the rate and make up for lost time. You have a bunch of strategies coupled together with what's called top-down or pep-up therapy. You start with all your tricks and then back off as tolerance develops. You start at goal rather than a slow ramp-up. You use the volume-based feeds. You slap the calorie balance, caloric balance, and the deficit all over the chart so the docs know we're 2,000 calories behind. Nope, we're 4,000 calories behind. You start with probiotics, you start with prokinetics and take them off as the patient develops tolerance. Have nurse-driven protocols in place. Avoid making them put them on clear liquids. Avoid making them NPO after midnight for a CT scan. Make them NPO after 6 a.m. Bundle these things together into 5 action statements. These are all ways you can increase delivery of nutritional therapy. Now, when is it appropriate to back off and provide less therapy? So this is important. These studies have brought out that some patients we don't have to go crazy and be a zealot and get up to goal. I think there are 3 scenarios where it's totally appropriate to back off and feed less. The first is what we've already talked about, Todd Rice's notion that ARDS and ALA patients, acute lung injury on mechanical ventilation just for the first 6 days they're in the ICU. It is totally appropriate to feed them at trophic feeds. And that's about 25% of goal calories. But make sure that there are no extremes of age. Remember, those patients were 52, no extremes of BMI, and that they're moderately severity of disease. If they're very sick, very old, low BMI, high BMI, then you better rethink that strategy. And make sure if you order trophic feeds that they get the trophic feeds and not half of that. The second group is the obese critically ill patient. This is a group where we don't back off of protein, but we back off on calories because their weight messes up all of their management. So we actually have formulas. We're really pushing the protein on them while we back off of the calories and give them about 60% of their caloric requirements. The third group is any critically ill patient that ends up on TPN. And there is candidates that clearly need it, usually after the first week of hospitalization. But if they're on TPN, you would back off and provide 80% of caloric requirements. You can give full protein. But that improves insulin sensitivity and improves that narrow risk-benefit ratio. This is the rationale in obesity for the high-protein, hypocaloric feeding. We have physiologic studies for this, no randomized trials. So up here at the top, we're backing off on the calories. We're going down like this. And so what that lets us do is pull body fat. So as we move into, this is the death zone where we're pulling off body fat. But what this shows is if you jack up the protein high enough, you can actually climb out of the box for lean body mass. So conceivably, if you give enough protein while you're backing off on the calories, you can actually maintain lean body mass and pull fat mass. And that's what we would want from our nutritional therapy. We don't have randomized trials to support this, but physiological studies say this is a good idea. And then this is the data on any patient that ends up on TPN. You'll want to back off, at least for the first week of therapy, to 80%. These are a meta-analysis of 5 studies, mainly in surgical ICU patients, in which they gave 80% or 20 calories per kilogram per day instead of 25. And what they showed was that infectious complications were less, 40% reduction, hospital length of stay reduced by 2.5 days if you gave 80%. It just improves. You're more likely to benefit from the TPN, less likely to have problems. So what direction are we going? Have we shut this down and are we turning the corner and now we're back to status quo? And the answer is no. It's just starting. I included this because I got an email at 5 o'clock yesterday. I'm busy getting my slides ready for this morning. And I got this email from a dietitian in Chicago. It was from the General Surgery News. This may be on your coffee table at home. But the Surgical Infection Society met this week. And this was a randomized trial by Eric Charles, was the lead investigator from University of Virginia, SICU setting, 84 patients, randomized to get half of caloric requirements versus full requirements. Every patient got normal protein, or the normal amount of protein. At the end of the study, there was absolutely no difference in the ICU or hospital length of stay, infection, or mortality. And this, I just couldn't, I didn't want to miss this because of the irony of it. Here's our own Bill Cheadle, who I love, great guy, great doc. He's the current or past president of this society. That's why they cornered him and asked him to quote on this study. And here's his quote down here, that the risks are lessened when the amount of calories needed are less than the traditional amount. This study shows that feeding less in the ICU may be better. And Bill's a great doc, but this is just the start of these studies coming out in which we're moving away and feeding less is better than feeding more. But this isn't as scary as this situation. In December, right before Christmas, I got a little Christmas present. I got a call from the editors at New England Journal and asked me to write a review on feeding the critically ill patient. And I got 2 of my buddies, Bob Martindale and Darren Highland, and I spent, and with these 2 guys, 3 months. It had to be 2,700 words. Every sentence was perfectly structured. I mean, everything was referenced. We argued. There was no fluff. It is the hardest paper I think I've ever written. We turned it in March, and we got it back in 2 days. And the editors was Simon Finfer, who was on the Surviving Sepsis Campaign, and Jean-Louis Vincent, the guy from Brussels, who's also on the Surviving Sepsis Campaign. And they get it back in 2 days, and they said, we want this to be a balanced discussion. And we kind of thought, yeah, we thought it was. And they said, you need to tone this down and be more balanced. So we took another 6 weeks and reworded the paper and turned it back in. About a week later, we got the reviewers' comments, and they're shown here. It was 12 pages of reviewer comments. Reviewer number 1 had 5 lines, and we had misspelled an author's name, and then he said that this was an effective review showing the value of enteral feeding in the ICU patient. The next reviewer went on for 11.5 pages and just shredded us. Interestingly, this reviewer referred to the Panic study 7 times. There was a full half-page defense of tight glycemic control. It wasn't too hard to imagine. It's anonymous, so we don't know who it was, but sure sounded like Vandenberg. And here are her comments. The authors, these clowns up here, overinterpret low-quality observational studies, whereas the high-quality RCTs better fit the overall storyline. Patients with severe nutritional risk should benefit from early enteral nutrition. That's what these guys say. The opposite is true. They don't benefit, they do worse. And based on older observational studies, Krishnan, this is one of the worst studies I've ever read, and recent RCTs, the Cesar Panic study, long-stay ICU patients are more likely to be harmed by enhanced nutrition. And the conclusions from recent RCTs, the Eden Omega ARSNet study, the Swiss supplemental PN, and the Panic show that patients receiving more protein and energy have worse outcome. Throughout the review, she said, take out this paragraph and write this. She was actually giving the sentences verbatim that we were supposed to substitute. And then guess what the editors did at the end of this review? Guess what they did? Gave us another 6 weeks to work on it. They rejected the paper. An invited review. I didn't think this happened, but they rejected an invited review. And I was just torn up. I was on vacation. It kind of dampened the vacation a little bit when I got the email. So I called him, and he admitted that Jeff Drazen, the editor, and the associate editors were not experts in nutrition. He admitted that he had asked experts in nutrition to write the paper, but he said, we just know what we want it to say, and we don't think we can get there with you, so it's better to jump ship. And then I was I made a vow that I would get off the phone before I'd start yelling at him. And I wanted to say, you guys are playing God. But I said, I've had self-esteem issues, Dr. Drazen, since I got this email. I said, has this ever happened in the history of New England Journal that you would reject an invited review? And they said, oh yeah, we reject 40% of our invited reviews. 12 weeks later, a buddy of mine called me, Paul Wishmeyer, and he goes, you wouldn't believe what I got to review. And I said, let me guess. Is it feeding the critically ill patient? He goes, yeah, how'd you know? And I said, who's the author? And I said, wait, let me guess. Reed Vandenberg? He says, yeah. And I said, how's the paper? And he says, it's terrible. He says, it paints this horrible picture of how devastating early nutritional therapy is and how bad it's going to hurt our patients. What I've heard is he mounted a huge defense. The last thing I heard was the editors are telling her what she can write and what she can't write, and we have yet to see the final paper. So this isn't over. We're going to hear more of this in the future. So in conclusion, the benefit of early nutritional therapy, of any nutritional therapy in the hospitalized patient, is due primarily to tube feeding. The value of TPN is not clear. And should be used only in high-risk patients on a case-by-case basis. That nutritional risk is defined by both disease severity, and we have scoring systems to do that, and we can define poor nutritional status by very specific markers, BMI below 20, weight loss, or reduced PO intake. And aggressive strategies for tube feeding can promote and increase delivery, increase your chances for better outcome, and reduce the need for TPN. But I'm telling you, we all have to remain, me in particular, I'm talking to myself here, we need to remain flexible because our understanding and our interpretation of this literature is going to change, and we haven't heard the lesson. So I'll stop there and hopefully.
Thank you, Steve. This was fascinating, very clear. Even a cardiologist can understand these things. I just want to make a brief comment before I let Christine run the discussion about the publication. So, as an editor of a journal, I know exactly. We do reject the invited reviews by maybe 2% of the time, and when they are really unreadable and they're off the mark. But I'm not surprised with your experience with New England Journal of Medicine. The editors are intellectually dishonest. They're thugs. Their goal is to push their own preconceived and biased and bigot agenda rather than stick to the truth. And that's true in many other areas besides nutrition. I had the same experience in cardiology as well.
Oh, thanks.
So one thing we know is we're really glad that Dr. McClave and his nutrition team are helping us with all of our patients, because otherwise we would not know what to do. I think he's taught us that a critically ill patient is not the same thing as an ambulatory patient with immunodeficiency, etc. I wanted him to comment, and so I'm asking you, Steve, to comment on the constant catabolic state, and if we have better markers of measuring that. And I'm bringing this up because he's a cyclist, and if he goes more than 50 miles, he's learned from me that you have to take glucose in order to restore your glutamine, because you actually have no more liver glycogen. And so that could be the reason why we're still all confused about the sepsis state, is we just fundamentally don't understand when you're in a constant catabolic state and all the cytokines are elevated, we don't understand exactly how to feed that person in that state. So I want you to comment on glycogen.
Three quick responses to that is we cannot shut off the catabolism easily. Well, our goal is to stimulate protein synthesis to match the catabolism. The second thing is just providing protein and calories in somebody who has cytokine-driven SIRS response is not enough. You've got to do something to turn that milieu down. And that's why immunonutrition sounded so great. Now it's not, we're finding out that in half the population we were using it in, it doesn't work.
Jesse Roman talked last week, the grand rounds last week, about how shutting down and using antioxidants, that an oxidant state may be beneficial for this, for mopping up we don't know enough about the organism, what it does in the septic state to mop up all those inflammatory mediators.
But the third aspect of that catabolism thing is the importance of maintaining muscle function. And so we're getting patients up in the ICU and ambulating them so that when we feed them, that increases blood flow and the nutrients to get into the muscle. And the tube feeding compared to TPN or doing nothing helps control insulin resistance. Right. Because if the muscles get glycosylated from hyperglycemia, they do worse.
Why do you think the over-protein feeding, was that just because it was TPN protein instead of enteral protein? Actually,
this is a new movement in nutrition now. It's not overfeeding, but we weren't given enough all those years. So they're really saying that's the most important of the three macronutrients, make sure you get enough. So a lot of these scenarios where we're backing off on calories, not protein.
It sure does look, though, that you've got more argument in the literature, the bulk of literature that you've presented today, that giving something every hour is very, very important and not having interruption. Again, because probably of this constant catabolic state. You don't want the patient's physiology to go into a starvation state.
Actually, that's a very important point. We are now thinking in terms of nutritional and non-nutritional benefits from our feeding. Every patient probably needs the non-nutritional benefits, which is like the 25% of goal calories in the gut to maintain integrity and shut down the gut axis lung of inflammation. But the patients that are high risk, they need the nutritional benefit as well, which is where you get up to goal because something else is missing in them, and they need the higher calories and protein to change outcome.
Last comment before open questions on microbiota. Is it still considered, and I know this is too simplified, that the reason you want to give enteral instead of parenteral is because you're also keeping your microbiota happy and stopping them from reverting to the aggressive forms?
Yeah, and the only thing there is we're just poised, waiting for these experts to tell us to use probiotics in the ICU, and they won't do it. They keep saying we're almost there, but he says it's also a little naive to give one bug. He says what we should do is replenish the garden. And so probably what's going to come to fruition is the fecal transplants that we're doing now where we give them enemas with the stool. They're going to take that and homogenize it, freeze it, put it in a pill, and we'll replenish the garden from the northern route.
Frozen yogurt will have a completely different appeal. Questions for Steve?
Yeah. Chip.
Particularly the data that you presented from the gentleman out of Vanderbilt in moderately ill patients.
Todd, yeah, right.
But so is somebody dealing with developing the data in sicker patients?
That's a great question.
Developed on relatively soft data.
Yeah, right. All I can tell you is that the burn guys have come to him, the trauma guys have come to Todd, and they want to reproduce that design in their patients. We just saw from the Surgical Infection Society in a surgical ICU patient, they're looking at a variation of that. So yes, people are taking it to other disease processes and sicker patients. The thing that upsets me, that Surgical Infection Society where Bill Cheadle was asked to comment, this was 84 patients. Did they do a power analysis? How did they know they didn't have a type 2 error, that they saw enough patients to know that there, in fact, was no difference between the groups? The Todd Rice's multi-center, they had 1,000 patients. They got enough patients. But we're going to see a lot of these smaller studies where there's no difference with trophic feeding, and we won't know if there really was a difference or not. That's what scares me. But yes, they're going to sicker folks. Yeah.
In the studies that are done where they compare enteral nutrition, I don't care when, early, late, or whatever, compared to what you call standard, now do those patients also have a tube down their stomach? I mean, or are they usually not? And I mean, is somebody flushing it with water? Or
yeah, no, that'd be good. You want sham feeding versus enteral feeding. No, it's not that clean. And that Lewis meta-analysis, about half of those patients were in a surgical ICU setting. The other half was elective surgery. The pancreatitis studies, they were sick. They were being operated. They were so sick. But I don't think we're going to – the early versus delayed is as close as we're going to get to early enteral versus no feeding. nobody ethically anymore wants to have an arm that doesn't get anything for a week. But you're right, it's not as clean as we'd like. Yeah, Mike.
Very, very nice talk. Thank you so much. Do you have any presence in the surgery department, in particular with preoperative patients? Do you work with them at all?
Yeah, I'm proud to say that several of the faculty have taken this immersion course. Keith Miller, Dustin Neal, although he just went to Kansas, Matt Bozeman. These are young faculty guys. Bozeman will go on the faculty next year. Chris Jones is going to take the course this fall. And these are guys that are getting this is an immersion course. They spend 2 weeks with me here and 2 weeks with Bob Martindale in Portland, and they're getting a full injection of nutrition, and they're really pushing the envelope and thinking outside the box, and it's great. So these guys are going to help shape surgical care, nutritional care in the future. Keith Miller was on a summit that we had last fall on nutrition therapy through elective surgery. He was one of the speakers, one of the faculty, and he's on our faculty here. So we're moving in the right direction. Yeah.
Dr. McClave, I've been watching you do this for 30 years. You're still one of the best teachers in the place. The older I get,
He's a friend of mine.
the older I get, the more impressed I am at how many of the things that we have done, that I have done, that made sense at the time, turned out to be harmful. I don't think there's anything we do that's without risk. Can you suggest some things from your perspective now in clinical nutrition that really have made a difference, and perhaps some of the things that have been as this, perhaps the wrong thing?
Yeah, I really still believe that in the right patient at higher nutritional risk, you change outcome with early enteral feeding. And the group that impressed me the most was severe pancreatitis. There is a huge mortality benefit when you get the tube in compared to TPN or do nothing. And that's the group that highlights it the most. There have been things along the way that didn't pan out, like immunonutrition in the medical ICU patient. Another was that in this model of catabolism that Chris was talking about, we tried beta blockers for a while, and thinking that we can just control the SIRS response that way. And it looked like it was working, and then people started having MIs on the, in the middle of the operation and having strokes through their big long Whipple. So that didn't work. So the tight glucose control was too tight, and the hypoglycemia ended up killing people, and we had to back off to moderate control. But moderate control was better than poor control. So you're right. And sometimes you get frustrated, well, what is the right answer? Well, we're scientists and the field evolves. That's why this trophic feed thing is evolving. And in some patients, it's going to be an adequate idea. Other people won't. You just got to watch as each trial comes along.
Thank you very much.